Good morning, everyone. Thank you for the organizing committee for the Egyptian Hypertension Society, Professor Mohsen Ibrahim, and all the board of the society and all the board of the organizing committee for inviting me to share in this important session. My topic will be about the microvascular angina and hypertension. The clinical cluster of typical anginal chest pain, a positive response to stress testing, and angiographically normal coronary arteries is known as microvascular angina or cardiac syndrome X. This condition is relatively common in patients with systemic hypertension. The mechanisms underlying angina pectoris in essential arterial hypertension patients without obstructive coronary artery disease are still largely unknown. Several functional pathophysiological abnormalities have been reported in these patients and have been postulated to represent the pathogenetic basis for angina in these patients. This includes endothelial dysfunction, increased sympathetic tone, microvascular spasm, estrogen deficiency, psychological disorders, increased pain sensitivity, insulin resistance as a part of metabolic syndrome, structural abnormalities of the arterioles, including capillary rarefaction, medial hypertrophy, and fibrosis. So we'll go through some of these items in the following slides. Let's start with the endothelial dysfunction. The presence of endothelial dysfunction has been suggested by reduced coronary flow response to acetylcholine or atrial pacing, and by inappropriate endothelial vasoconstriction activity, mainly mediated by endothelin-1 production. And although impaired microvascular function and structure is generally considered to be the consequence of high blood pressure levels, yet there is evidence that microvascular changes like capillary rarefaction and endothelial dysfunction may anticipate the clinical onset of arterial hypertension. The second factor is the estrogen deficiency in postmenopausal women, and this is associated with the loss of direct protective effect of the hormone within the vessel wall, and indirectly with the negative changes in several other traditional risk factors for coronary artery disease, like increased blood cholesterol, increased body weight, and insulin resistance. Estradiol 17 beta has calcium channel blocking properties, thereby acting as an endothelial independent vasodilator. Therefore, the loss of estrogen negatively affects both the endothelial mediated and dependent and the endothelial independent vasodilatation with consequent effects on the blood pressure, causing arterial hypertension and impairing coronary vasomotion. A third cause is the insulin resistance, and the metabolic profile in patients with microvascular angina suggests a pathogenetic role of insulin resistance and hyperlipoproteinemia in the setting of impaired myocardial coronary reserve and in early stages of hypertensive heart disease. Another factor, which is an important factor, is the autonomic nervous system effect, and that the sympathetic and parasympathetic nerves can modulate arterial tone, directly acting on the vascular smooth muscle cells or stimulating the release of nitric oxide from the endothelium. Sympathetic control of coronary vasomotor tone is negligible at rest and depends on the balance between the beta-adrenergic mediated arterial dilatation, which is the prevalent one, and the alpha adrenergic mediated vasoconstriction that has only a limited effect. But when the coronary circulation is impaired by endothelial dysfunction, the alpha adrenergic mediated vasoconstriction becomes more intense, reduces the blood flow, and may lead to myocardial ischemia. Also, another important factor is the structural abnormalities of the arteriolar vessels, and here the hemodynamic load of hypertension may induce rarefaction of the coronary microcirculation, leading to impairment of myocardial perfusion. The impairment of coronary flow reserve in hypertensive patients is independent of the presence and the degree of LV hypertrophy. suggesting that coronary microvascular dysfunction is the result of functional alteration of endothelial and smooth muscle cells, leading to vascular remodeling and increased microvascular resistance. So, what are the factors that correlate between coronary microvascular dysfunction in hypertensive heart disease? The progression from hypertension to hypertensive heart disease and heart failure cannot be fully explained by the myocardial response to elevated blood pressure, and that the development of concentric or eccentric left ventricular hypertrophy depends on the etiology of hypertension, whether it is essential or renal or endocrinal or any other cause, and the interplay of the pressure and the volume overload. So abnormalities in the microvascular function, structure, and perfusion may be responsible for the transition from hypertensive heart disease to LV dysfunction and heart failure in patients without epicardial coronary artery disease. To diagnose microvascular angina, we have some clinical criteria that includes first the symptoms of myocardial ischemia, whether it is effort or rest angina or sometimes angina equivalent. The absence of obstructive coronary artery disease, that's the presence of atherosclerotic plaque producing less than 50% diameter reduction on the coronary angiography or CT angio, and the presence of FFR more than 0.8 in the coronary angiography. Also, the third item is the objective evidence of myocardial ischemia, whether it is ischemic ECG changes during chest pain or stress-induced chest pain or ischemia by ECG changes with or without transient or reversible abnormal myocardial perfusion and or wall motion abnormalities in echo. Finally, to diagnose is the evidence of impaired coronary microvascular function, which includes impaired coronary flow reserve, coronary microvascular spasm, abnormal coronary microvascular resistance index, and coronary slow flow phenomena. So the diagnosis of coronary microvascular dysfunction in hypertensive patients is beyond the resolution of invasive and non-invasive coronary angiography. The diagnosis of coronary microvascular dysfunction is based on functional assessment of the coronary arteries, which can be performed using both invasive and non-invasive methods. Of the method depends on the clinical condition of the patient, whether it is acute or chronic, and the need for repeated assessments and the presence of comorbidities. So, regarding the invasive diagnosis, the assessment of microvascular function includes testing the two main mechanisms of microvascular dysfunction. That is A, independent microvascular vasodilatation, and B, impaired endothelial dependent dysfunction. And this will depend on the coronary flow reserve, the index of microvascular resistance, and the microvascular. While the non-invasive diagnosis depends on the positron emission tomography, which is the reference standard non-invasive assessment of myocardial blood flow and the coronary flow reserve by quantification of myocardial blood flow at rest and usually induced maximal hyperemia. Also, cardiac magnetic resonance is used to assess the myocardial perfusion. So regarding the management of microvascular angina in hypertensive patients, evidence-based guidelines for treating cardiac syndrome X are still lacking. This is due partly to the lack of a clear understanding of the pathophysiology of the syndrome, and partly to the lack of sufficiently powered randomized control. A comprehensive prevention program includes recommendations of lifestyle modification, including diet, exercise, body weight reduction, quitting smoking, behavioral and psychosocial issues, that may positively improve the endothelial function and microvascular dysfunction. In this setting, a recent paper was published about the comprehensive treatment of microvascular angina in overweight women, which was published in last November. And they concluded in this paper that a comprehensive risk factor intervention, including major weight loss, resulted in a significant improvement in the angina burden of those women with microvascular dysfunction. So reducing the body weight in the postmenopausal women with hypertension and microvascular angina is an important aim due to the positive effects of weight loss on both the blood pressure and the insulin resistance. Concerning the pharmacological management of the microvascular angina in hypertensive patients, we have here the angiotensin converting enzyme inhibitors that are the therapy of a choice in this setting, given their beneficial effects on the blood pressure, endothelial function, and exercise-induced ischemia in cardiac syndrome X. These drugs have been shown to improve endothelial nitric oxide bioavailability, microvascular function, total exercise capacity, and exercise duration in patients with coronary microvascular dysfunction. The activation of the bradykinin axis by the ACE inhibitors may be a potentiating reason for excellent response of these agents. The angiotensin receptor blockers, also the telmisartan and the olmesartan, have been shown to improve the microcirculation among hypertensive patients, and that olmesartan is more potent in controlling hypertension and reducing inflammatory markers. Other pharmacological management for the hypertension and the microvascular angina is the use of beta blockers that have been shown to reduce the frequency and severity of angina and to improve the exercise tolerance in patients with cardiac syndrome X. Newer beta blockers with a positive effect on the nitric oxide release, such as the carvedilol and the nebivolol, are likely to be more effective in this context. Also, calcium channel blockers have a role that they act at the level of prearterioles. The non-dihydropyridine, verapamil, and diltiazem also reduce the heart rate and can be used in the patients who are intolerant to beta blockers. Adding aldosterone antagonists with ACE inhibitors has been shown to improve coronary endothelial function among women with coronary microvascular dysfunction. So, in conclusion, Mr. Chairman, dear professors and colleagues, systemic hypertension is often associated with microvascular angina. Several pathogenetic mechanisms have been identified which represent suitable targets for treatment. Microvascular dysfunction needs to be investigated and treated if present in patients with systemic hypertension, angina, and angiographically normal coronary arteries. ACE inhibitors, ARBs, beta blockers, and aldosterone antagonists, in addition to lifestyle management, are among the therapeutic options used in this setting. تحياتي لكل الناس اللي حاضرين في المؤتمر وتمنياتي بمؤتمر سعيد والف شكر لحضراتكم.
Thank you very much, Professor Sameh, for this elegant talk. And any question from the floor? Okay, thank you all, and we close the session now.